So it's my pleasure to introduce a colleague and friend, Dr. Patrick Conway, who is going to be our Grand Round speaker today. Dr. Conway always times his entrances so that he has a maximum participation before he gets started. But I think we couldn't have a better person to give Grand Rounds today on this topic of healthcare transformation than Dr. Conway. Dr. Conway is currently the Chief Medical Officer for CMS, which is the Centers for Medicaid and Medicare. In his role, he oversees the health of over 130 million Americans who are enrolled in Medicare, Medicaid, CHIP, or the healthcare marketplace. And in addition to that, he oversees a $10 billion budget over 10 years to improve the health care of all Americans through a CMS innovation project, which is geared towards trying to increase the access, affordability, and quality of health care for all Americans. I know Dr. Conway for about the past 10 years. I know that he graduated from Baylor before he completed his pediatric residency in the Harvard program at Boston Children's, and then received a master's in science in health services research at Children's Hospital of Philadelphia. I think my claim to fame is I was smart enough to try to recruit Dr. Conway to join our hospital's medicine division 10 years ago. He was attracted away by Cincinnati Children's, where he was named the medical director for their hospitalist program and also the associate vice president for healthcare outcomes. He was attracted back to DC, though, for Health Services White House Fellowship under Health and Human Services, where he was recognized for his talent and tapped to be the Chief Medical Officer for HHS. He's been in DC ever since, and we were successful in attracting him back to Children's National, where he is a member of our hospital's medicine division. It gives me no better pleasure when I'm on service on the weekends to work beside Dr. Conway. Dr. Conway, though, is recognized for his academic as well as his administrative leadership in transforming healthcare across America. He's a member of the Institute of Medicine, as well as receiving awards from President Obama. So let's welcome Dr. Conway.
Thanks a lot for the kind introduction. Really great to be here today. I do apologize for being late. My teams will know I like to never start late, so that makes me feel even worse about it. I'll blame traffic, which is actually true. Apparently, on the weekdays, it's a lot worse to get here. On the weekends, especially when there's a lot of accidents. I did work here clinically, not last weekend, but the weekend before. Have the honor to serve and do that about every 6 weeks. So really love my time here. I actually had we have somebody who's going to medical school next year, working in the Innovation Center, when I followed all the protocols, but it came and shadowed me this past weekend, and just a pleasure. You know, he just another example of somebody early in his career who is seeing policy at CMS for a year, is going through the medical school process, and he really enjoyed his time sort of seeing the direct patient interaction. I sometimes get asked why I still do it. I have to admit, you should almost ask me the other question, why do I do my main job? Because the time spent here is just wonderful. I will still end on time, including some time for questions. I know a lot of you have to go back to patient care and other things. I do want to give a couple framing comments to this group before I dive in, just contextual. So I have been Chief Medical Officer now for about 6 years. That is the longest serving Chief Medical Officer in CMS history. Which I don't know what that says about me or the job. I'm not a political appointee, so I plan to hopefully go through the transition. It is both by far the best job I've had in my life. It's also by far the most challenging. For context, we insure about 140 million Americans now. About 60 million of that is through the Medicare program, a little less than 60. About 70 million of that is Medicaid and the Children's Health Insurance Program. So obviously, huge, 70 to 75, huge player for children, and we can talk about that. and then about 10 million is the marketplace. So actually the marketplace, less than as much as Obamacare is in the news, and marketplace is very important. I work on it a lot. Just from a scope perspective, less than 4% of Americans, a sort of minority of our actual book of business. But obviously in today's environment, a lot of rhetoric. We spend about $1 trillion a year out of CMS now. That's over $2.5 billion a day. That's over 100 million an hour. So what I talk to our staff about is how do we maximize the impact of that spend in terms of better health outcomes, better care, and smarter spending. I have to give Don Berwick, my first boss, credit for that. I think he really has instilled a triple aim culture in CMS that we continue to work on, but I think a culture of collaboration and real transformation. And we're trying to live that ourselves by deploying lean and other model for improvement and other techniques throughout our own work. So I'll talk a little bit about the delivery system and our goals, a little bit about the Innovation Center and Medicaid and Pediatrics. And I will, as I said, try to go relatively quickly. I'm happy to share my slides and then definitely have time for questions. Is Andre here too? You guys may not know this. You have another pediatric hospitalist who we just hired as Chief Medical Officer in the Center for Medicaid. So he does a lot of nights here and stuff, so I know he's also slightly incognito. But Children's National now has a trend of people. And we hired one of your chief residents who was wonderful in our oncology care model and now is in District of Columbia. But I think, and I've mentored through the REACH program a number of residents. We really are trying to be supportive partners. So if you think about our evolving state for healthcare in the U.S., I think we really are moving to a patient-centered, outcomes-oriented, sustainable, much more coordinated care system built on value, ACOs, bundled payment, transparency, quality improvement. I was on a panel with Don Berwick a few months ago. Well, I mean, it's more from him than me, but I agree with him. He said he thinks we've seen more positive delivery system reform in the last 3 to 5 years by far than ever in U.S. history. I actually think that's true. He also said, but we've got a lot more work to do. I also think that's true. I won't go through the details of this case, but there's a child I had on service that if I know you, it's probably not a good sign because I work only weekends. And I came on and I heard the name and I said, enough said, know who it is, know him well, talk to the father, we bonded again. Has been in this hospital, I don't know if it's still here, but when I saw her over the weekend, 100+ days, and a series of policy and social and other issues that have resulted in that, which is obviously not good for this hospital, not good for our system, but most importantly, not good for her family. And I think, unfortunately, we still have a system where that can exist. I'm always careful. I was tempted on that one, and we can talk later, to call the Medicaid director in D.C., but I'm always careful that, we can talk about that. I do try to separate the roles. I'm your doctor. I'm not. I was tempted, and we can talk about that, because I do casework, so you should probably email me at my CMS email and be like, we have this case, and I'll refer it into our Medicaid. And I probably would not actually admit to the team that I took care of her, because I don't want to be seen as a conflict of interest. But it's a real example where our system is not as supportive as it could be. So we are thinking about how we pay providers, how we deliver care, and how we distribute information in this transformation journey. This payment framework, you don't have to memorize the details, but I think is relevant in pediatrics as well. Category 1, fee-for-service, no link to quality or cost. I think really across payers, you're seeing that trend down over time, and I'll show you some Medicare numbers in a second. Category 2 with fee-for-service with link to quality and cost in some way. So these are things like value-based purchasing programs. Pediatrics, one of the challenges, honestly, is what are the right measures, and are we measuring the right things? And we can come back to that, the outcomes that are really meaningful to patients and families. Category 3 is alternative payment models like ACO models or bundled payment. I'll try not to use too many acronyms. And category 4 is population-based payments. So these are an example for us is we have accountable care organizations now that are provider organizations that we pay like health plans. We say, this is your patient population, here's your quality targets, here's your cost targets. You beat those, you do well on quality and lower cost, you know, you keep all of those savings. And we give them a ton of flexibility about how they manage care, and I'll come back to that as well. You know, Cincinnati Children's, and it's evolved since I left, but, you know, we had ACO contracts, we had bundled contracts. I'm sure this hospital has a similar sort of mix, but you can tell me afterwards. You know, liver transplant, at least at that time, it was an all-in bundle. It was, you know, we'll care for your child for life. Here's our quality outcomes. Here's the bundle. We hope you choose us as a provider. You know, on the flip side, for the population around Cincinnati, was also a low-income population, where it was, you know, we want to care for zip codes of people and children because it's 100% catchment into Cincinnati, and we'll try to decrease preterm birth and prevent NICU admissions, et cetera. So, you know, I think those systems can coexist. It's a fair point. You need payers that are willing to play with you, and you can tell me how well that exists here. I've heard some of it. And I will say we're trying to push on the other side on our payers, including in Medicaid, that they do move to some of these new payment models, and I'll try to weave some of that in. So we set a goal to have 30% of payments. In early 2015, the president announced a goal of 30% of payments in alternative payment models by the end of 2016, and 50% by 2018. If you want to get a good laugh, you can actually, I think it's still on YouTube, you can YouTube me introing the president, and I'll give you the backstory on this. So, you know, it said, you know, you're going to introduce the president, you can talk for 30 seconds or 15 minutes. Just make sure when we tell you to get off stage, you get off stage right away. I'm like, oh, okay, all right. I'm like, 30 seconds to 15 minutes, it's pretty long range, but, you know, I can be flexible. And I said, you know, it's going to be clear what the signal is. Like, you know, what is the signal? Being a good readback feedback kind of doctor. Like, it'll be clear, don't worry about it. Okay. So there's two of them on opposite sides, and they're literally giving opposite signals. They're like, longer, longer. Cut it off, cut it off. So I'm like, you guys, this is why I said read back feedback. Who's going to give the signal? Like, we both agree ahead of time. So you'll see me going longer, shorter, longer, longer, and then eventually just cutting off when they both said cut it off. We reached that goal actually ahead of schedule. I think part of the reason we reached the goal, by the way, is we set the goal. So it's classic improvement method of setting an aim and measuring. And then we set 85% tied to quality and value in some way. Actually reached that goal a year ahead of schedule as well. This fall, we're going to report these numbers across payers, including Medicaid. I can't give you the details of it yet, also because we're still running the numbers. But I can tell you nationally, across Medicare, Medicaid, and commercial, the trends are fairly similar in terms of very low alternative payment model uptake and then heading towards that 30% number. And our hypothesis is we do think you're in Medicare, which we have the most control over, you know, I think we'll hit the 50% number. I think we're going to shoot for that 50% number for alternative payment models for Medicaid and commercial as well. Obviously, Medicaid, as you know well, an interaction with the states is going to vary by state. And, you know, in the commercial market, can't force them to do things, but can put a series of policy levers and other things that I'll talk some about to encourage. So this just shows the trajectory. The main new point on this slide, the dark blue is alternative payment models for Medicare. We were at 0% in 2011. So 20% by 2014, 30% by early 2016. So pretty strong trajectory here. Healthcare Payment and Learning and Action Network, I'm going to talk briefly about. We think public-private partnership is critical. This is one of our mechanisms. So this network has 8 of the 10 largest private payers in the country, has over 25 states, has thousands of provider organizations, consumer organizations, and the whole point is, you know, how do we embark on this journey together? So we first agreed on definitions, which actually ended up being those same 4 categories I showed you, but with some subcategories, just to make it more complicated. When we were doing that, I was like, I think 4 is enough, but we ended up with like 4 with a bunch of subcategories. And then I think more importantly, we're now working across things like ACOs, bundled payment, primary care medical homes. How do you align across payers? So how do you have the same quality measures across payers? How do you have the similar same risk adjustment methodology? How do you have a similar same attribution methodology, which, you know, if you are the administrator leading efforts, That's important. When I was in Cincinnati, I used to have to report quality measures to every payer and external entity that wanted them. When I left, there was 700 plus. I don't know if it's worse or better here, but it was that makes it hard. And the reality of what we did is then we had a much narrower set of measures that we were actually trying to improve, which we called our system level measures. But imagine if you live in a world where payers have aligned on a small set of quality measures, that'll allow you to really drive improvement much quicker. Similarly, things like attribution and risk adjustment matter in terms of, if there's alignment across payers, that can help drive transformation. I'm going to skip this slide that just shows the level tied to quality and cost. So I'm going to shift gears now and focus a little bit more specifically on Medicaid and pediatrics. So Medicaid expansion, 31 states plus DC. So we continue to add states. I won't go through all the evidence here, but a growing body of evidence both in terms of the improvement of health outcomes for Medicaid expansion. Also, interestingly, it's looking more and more like improvements on things like economic output at the state level. So Medicaid expansion has a number of benefits both in the health and non-health arena. We've said to all the orange states, we're willing to work with you, including, if there's certain waivers or other things that would get you to Medicaid expansion, we're willing to do that. There are some policy parameters we're not willing to do, and we try to be clear with states on that. But our goal is, of course, as the administration has said, to expand Medicaid nationally. This just shows, some of you probably know this data, but children are actually almost 50% of the Medicaid and CHIP enrollees, but about 20% of the cost. If you break that down further, you've got your complex children that are obviously a large portion of the cost within the children bucket. Obviously, neonatal care and some other areas also large portions of the cost. Then you've got a lot of well children. On the well children, I will say, and we can talk more about this in the Q&A, we have a team, and children generally, we have a team in the Innovation Center right now thinking about, do we need a more direct pediatric model? I'll talk about some of the things we've already done. And this could be around complex kids, it could be around early childhood bundles, the sort of 0 to 5 age group, it could be around mental and behavioral health. So, we don't think we're done. Probably won't ever be done, but we think there's a lot more work to do in the pediatric arena as well. We are at historically low uninsured rates. I mean, the good news is nationally we have the lowest uninsured rate in U.S. history right now. So I would argue that's good news for America. And for kids, we have the lowest uninsured rate for kids. That doesn't solve all the problems because having an insurance card doesn't mean you get optimal care across the whole life course, but that is a huge step that we should feel proud about. This just shows the rate of uninsured 2008 to 14, so you can see the drop here. Briefly, we do have a child core set for Medicaid, which Andre will get to work on now. That's evolved over time. 23 measures now, crossing primary care, perinatal, acute and chronic conditions, behavioral health care, dental and oral health. Actually, yesterday I wanted to mention we announced we had funding for pediatric measures that went to centers of excellence across the country, things like patient and family experience that Boston happens to be working on directly for kids and families, really exciting. Readmissions tailored to kids since kids are different than adults. Set of neonatal measures, set of access measures, set of primary care measures, set of measures around complex kids. So, I think this is an opportunity with that measure development to bring those into the core measure set so it becomes more meaningful to kids. And we just announced yesterday the continuation of those awards. So we're investing more money so that we can both implement the measures that we've already developed, plus develop some additional measures over time. So I do think, if I look back, still more opportunity to improve pediatric measures that I think better today than they were 3 years ago. And I'm actually hopeful with these sort of centers of excellence may have an even more robust set 3 years from now, and including some patient-reported outcome measures for kids as well. This just shows some of the results. I'm not going to go into these in detail. Let's call out a few. Access to primary care, actually quite good in the sort of blue area up top. One thing I wanted to call out, mental illness, this is true for pediatrics and adults. So, these measures, follow up after mental illness, 43%, follow up for ADHD, 44%. Our measures in mental and behavioral health, both in pediatrics and adults, are, I would argue, seriously lagging. I'd also just argue at like a fundamental level, our mental and behavioral health system for children and adults, unbelievably serious gaps that are causing challenges, both in terms of quality and cost. This is an area that I think you will see the Innovation Center, the administration, one of the candidates has called it out as one of her, and I'm not political, so I can't endorse anybody, but one of the candidates has called it out as a major platform issue, mental and behavioral health. You have zip codes in this country, for the first time in history, life expectancy is going down. Like, literally, there's a JAMA paper on this. We had seen the data before they published it. And it's largely substance abuse and mental health, behavioral health issues. It's opioid, substance abuse, mental and behavioral health. And you've got zip codes where life expectancy going down in the United States. And so I think, and actually both, I've had to solve for this for family members and for kids. It's like, I don't want to say ridiculous, but it is a unbelievable challenge that just shouldn't exist. And you have mental health parity and other things that have been passed that I think should improve this over time, but in reality, on the ground, you need it to actually have parity, not just parity in law, but parity in action. The Kennedy Forum and some other folks were doing some work on this to try to push this forward. This is some of the access measures to primary care. Actually, I'll talk about that later. I was going to go into primary care a bit more, but I have a slide later. This is central line infections. I mean, this kind of work we should feel good about. I mean, in pediatrics, central line infection, one of the people in the room was my fellow when I was a resident. We had a child when I was in the ICU die of a line infection at that time. It really wasn't clear like how preventable these things were and how to prevent them. It was more when the evidence was emerging. You now clear evidence, New England Journal studies since then, and we've implemented at scale. So nationally, line infections have gone down dramatically for adults and kids. And these are, real people not dying, not having major events. So, I mean, collaboratively, we work on these improvement arenas. You can see a dramatic national improvement. This shows some of the central line numbers. DC, Maryland, Virginia, you're all decreasing since the baseline period. Briefly, I want to talk about home and community-based services, and a number of folks in the audience probably more expert on this than I, but we are increasingly in the Medicaid program, as you think about long-term service and supports. You can see the trend from 95 through 2013, moving away from institutional settings and moving into home and community-based settings. And so we think this trend will continue. This then gets to, how the home and community-based settings get as family and patient and caregiver-centered as possible and the best possible outcomes. Still more work to do there, but trending away from institutional settings. The one I won't name the state because even though it's public, I don't know if she would want me to. I was with the Secretary of Health from a large state a couple days ago. We went through, I get a report every morning. It has an official name. I call it Bad Things That Happened in America Yesterday. That's not its official name. And it's disconcerting. So some of them you can imagine classic Swiss cheese. You can imagine how it could happen. On the other end of the spectrum, and then I'll get to home and community-based services. The worst example was a nursing home where the owner built a meth lab in the nursing home, which exploded, luckily not killing any residents, but killing 2 employees that were also meth lab employees plus nursing home employees. We have a protocol that we give people a week to respond before we terminate them immediately. This was one I was like, no, I'm pretty good. There's no actual explanation that would make sense. We can terminate them today. In the home and community, and this is hard, and some of you may be aware of some of these issues. We have institutions that have existed for decades that have children that may no longer be children, plus children in. In this state, there was one with series of horrible events, from abuse of every kind to quality and safety events to other things, to the point we had to terminate the home. Got in a big, angry fighting match with the state, to be frank. And at which point I was like, I got to tell you, I have to enforce the standards. I feel bad for you too on your budget problems, but like this can't go on. The person actually came in a few days ago and thanked me for that. She's like, I know I like screamed at you when you were in your basement, but because we were on the phone. But she was like, that actually forced my legislature to fund in different ways, and it's going to take us time, but we were in a very challenging spot. So you actually terminating our payment in the end actually helped us. You don't actually get those calls that often. I have another one right now in a different state that they're not there yet. So we're working on that. And I'm still waiting. I'm waiting for the day a senator or Congress. Do you guys tape this and put it on the web? Actually, I should have asked this. Is it on the web? I can say this. I would say this publicly. I'm going to say it a little differently. It would be nice if at some point a senator or congressman were to call me and to say, thank you. Thank you for terminating the facility that had all these issues in my district, as opposed to and I get why it's hard. I mean, there's real issues, so I don't want to minimize the sort of challenges here. But one could argue that, we view our sort of quality and safety role, which is evolving over time, and really is evolving. So it's also, you've got a big, middle, and high performers that I tell our team, we got to learn from the high performers. And the big middle, we just got to help them improve. Because I think sometimes we focus too much actually on the tail. And that can lead to over bureaucracy. You could give me your example of whatever survey you had that made you frustrated. And so, I think we're trying to have a more dynamic view. Healthcare Innovation Awards, we actually fund quite a few in pediatrics, including one with the Children's Hospital Association, focused on complex children. We've funded asthma work. Were you guys involved with I know you do asthma work. I can't remember if we funded. I should always check what all we funded before I give a talk. But we've done, I know CHA, yeah, you are involved in. So CHA, pediatric asthma-related work, complex kid work. So a number of innovation awards in pediatrics. And this isn't uncommon for us. Now that we've funded a lot of innovation awards and we think we've learned, now we're in the stage of how we develop a broader model or set of models. So to give you a tangible example, we funded some oncology work, largely in the adult population, through innovation awards that looked like it worked. And now we have a very large oncology model that's 25% of oncologists in the country, that they're basically in an oncology medical home with an episode-based payment around that. And so you can imagine in pediatrics, our goal is we did a bunch of innovation awards that we're learning from, including ones that Children's National is involved with. And now we're trying to think about, could you make those a portfolio of a model or models that then could be scalable for kids? So we're doing that work now. This names some of them, Nationwide as a full risk global capitation model. And we can get you more information on any of these if people want. North Carolina had statewide health homes. University of Texas Health Science Center, they published, I think it was in JAMA, this work, improved quality and lowered costs, focusing on the high-risk children. So a number of innovation center models focused on pediatrics. In our round two, actually 25% of the awards were pediatrics. And so, still more work to do here. I'm not going to tell you that I think we focus enough on kids. I think we could focus more on kids. But I think good news in that as we're doing our funding decisions, kids are an important focus area. I want to name, you're also involved in this work through the Pediatric Safety Collaborative, the Solutions for Patient Safety. This is great work that when we release the results, it never gets quite as much press as I would think it might get. We've done work in hospitals across this country that Don actually started, Berwick, and has continued over the last 4 years. This data is ARC National Scorecard data, so it's gold standard random chart review. So 30,000 random sample chart review. And we had a 17% reduction in all-cause harm, 40% in what we think is preventable. We're trying to move away from the preventable metric for reasons people know. It's what's preventable, what's not preventable today could be preventable tomorrow. That reduction is 87,000 lives saved, over 2 million injuries and infections and adverse events avoided, and $20 billion in savings. And I'll tell you, the pediatric network here, the results are great, and they're actually teaching the adults things. You know, and certainly Steve Muthing and others would tell you they're learning from the adult systems too. But I can tell you that, you know, the pediatric safety work here has been a leader for the networks across the country. And this involves 80% of the hospitals in the country now are involved in this collaborative network, agreeing on measures, measuring and improving over time. You know, early elective delivery in this country is down 70% nationally. And this is not just, I mean, I'm not saying this is just CMS. This is you all as providers, it's March of Dimes, it's, you know, societies, it's lots of people. You know, we can try to contribute by funding improvement work and by, we actually publish our data now on early elective delivery, et cetera. But that's, you know, a very positive sign for kids. State innovation, briefly, we're partnering now with 38 states directly through what's called the State Innovation Model, really working with states to achieve better care, better health, and lower costs for their whole state population. We encourage them to involve at least 80% of the population. We do encourage them to involve pediatrics as well. Not surprisingly, probably some variability on how much states tackle the pediatric issues. And just to give you a few examples, you know, Arkansas is doing patient-centered medical homes, including for pediatrics. They've got all their payers involved, so it's truly an all-payer model in Arkansas. Minnesota did accountable health communities, so really linking social determinants of health with the clinical care infrastructure. Oregon did these coordinated care organizations, which are sort of like accountable care organizations, but also with social supports and more of a geographic attribution model. Vermont, we just announced a tentative agreement, which we'll probably sign next week. They're moving their entire state into an all-payer ACO. So what that means is they're saying the whole state's population will have a provider who's accountable for them. When I say provider, you know, it could be a set of, they have an interesting model where actually there are 14 hospitals, like you can't make this up. They're like literally distributed, so it's like you've got 14 hospitals and clinics that all like map to each other. Like, you're like, go figure, go Vermont. And so you're actually able to do a model where you said, you know, these people, this group of doctors and a central hospital and, you know, post-acute facilities, et cetera, you know, you're going to be responsible for managing this group of people. You have quality targets, including true population health targets, so decreasing substance abuse at a population level, you know, improved outcomes at a population level for a number of quality measures. It's across all payers, across providers for their entire state's population. It also gets you out of what the providers will say. So we met with the CEO of University of Vermont. I mean, he was like, I'm sick of trying to cross-subsidize stuff. He's like, I just want to manage care. And so, like, you know, you give me a payment model that's for Medicaid and my private payers and for Medicare, you tell me what you're going to pay me, and you give me quality measures, and you let me just do it, like, I'll take it. And I think there's a lesson there in the partnership that I think if you work, you know, the Maryland model, which I don't know if I have a slide on, isn't it? I do. I think there's a lesson there on the partnership that if you give people clear targets and you let them innovate, you know, providers know what to do. There's also an all-payer lesson. You know, if it's just Medicare at the table, not nearly as powerful as Medicare, Medicaid, and the commercial payers. Maryland has some unique attributes, but, you know, the old waiver, we moved to this global budgets for Maryland. We published this in the New England Journal. Cost in Maryland didn't just have lower cost growth, they actually went negative. We don't see that too often. So we usually say there's savings, but we actually mean it grew at 1% instead of 4%. This is actually with like a negative cost trajectory. Improved quality, improved safety results. A couple key lessons from this. This population-based payment model, for anyone who may not know, where essentially they said by year 5, and they negotiated hard for this, they would want 80% of their payments population-based, which would mean every claim gets paid at 20 cents or less on the dollar, and all your other financial flows are essentially from population-based payments. They said they negotiated hard, I remember, to year 5. They moved there in year 1. So after these first-year results, we sat down with all the CEOs in the state, like, guys, man, you negotiated with me like crazy to get to year 5, but then you moved in year 1 because they got to elect at the pace they wanted to go. What they said, I think, is also a lesson across their sort of CEO group. There was some variability, but they said, we realized we could like go part way each year and like try to flip our model and manage in fee-for-service plus a population model, or we could flip. And we thought if we flipped and we moved fully to a population model, it would actually help us with our physicians, clinicians, leadership do much better. And I do think that's why they got the results they got. I mean, now if you're a CFO in one of these hospitals, like the way you're successful is you keep people out of your hospital, which is a very, very different model. And you'll still take care. I mean, Hopkins is in Maryland, to state the obvious. You will still have some very high-end care that comes from all over the country, and we have methods to account for that, which I won't bore you with. But, for people in your surrounding area with CHF or a child with, 5 chronic conditions, the way you would be successful is to keep them healthy and out of the hospital. I'll speed up a tiny bit. Medicaid Innovation Accelerator, now Andre will get to work on. The core of this actually was like, I'll be a little more frank on some of this stuff. I was like, we got state innovation, but we got a whole set of states that aren't, you see all those white states on this map? That means they're not in state innovation model. None of them have applied. So from Texas to North Carolina, plus a bunch of states in the middle, they didn't apply because they didn't want to engage in Obamacare, is what they tell us. These states have a lot of health disparities. I'm from a small town in Texas. And so, we said we got to have, but what you hear from the Medicaid directors and the Medicaid medical directors is like, we want to do this stuff, but like, how do we engage? So we have Medicaid Innovation Accelerator, which works with any state in the country. We basically put out a series of issues that they help define for us. Things like substance abuse disorder was one of the earlier ones, behavioral health, long-term service and support, super utilizers. And then we have cohorts that work on that issue. What are the policy levers? What are the measurement levers? What are the improvement levers? And I think we're still learning how to do this, to be frank. There's capacity issues on the state side, and how do you bring stuff to them on a way that they really can implement? I think there's capacity issues, especially initially on our side, like how do we staff this work and support the transformation? So I think we're still in a learning cycle. It started in July of 14, as you can say, so we're a couple years in. But I think there's a real opportunity in the Medicaid program to support states in their transformation. This will actually lead to I don't have a slide on waivers. Historically, things like 1115 waivers, where states came in and they say, we want to redesign our system. Our interaction was probably not as robust as it needed to be, and it wasn't as focused on true delivery system reform as it needed to be. So now we have sets of principles around, leading with quality, really pushing states to different alternative payment models. Actually, it has to be one of the same states I just named, but if you have a safety net pool for hospitals, that's fine, but it's got to be tied to something. Like it can't just be, we have a formula and we dish out the money and we hope good things happen. It's got to actually be tied to like, what are the population health metrics? What will you do with that funding? What does that look like? So we think a big opportunity in Medicaid for more innovation. This slide we do understand this is hard at the front line. Most of my family members are private practice docs, mainly in the Midwest now. And, they want to, physicians and clinicians want to deliver high quality care to all their patients, but, my sister's a solo practitioner, a private practice doc. My brother-in-law is in a multi-specialty practice with about 30 docs. And it's like they need support to do this work. So actually learning from the safety work, this is about $650 million we're investing in these practice transformation networks and these things we call support and alignment networks, which are things like specialty societies and others, to really support physicians and clinicians to set aims, to use data to drive improved quality, to use improvement methods, to benchmark themselves. Our hypothesis is, 2 or 3 years from now, this started about a year ago, you may see results like we saw in the safety results, where you see, we've agreed on national aims and we've really moved the needle. And we're working with 150,000 physicians and clinicians across the country. Sorry, I have 4 kids 5 out of the 6 of us are sick right now, so I apologize about that. If you want to read more about sort of transformation at the front line, this was Karen Clancy, who is director at ARC, and I wrote quite a while ago, but we talk about core components, things like quality measurement, aligned incentives, evidence available, QI collaboratives, et cetera. So for Medicaid and the Children's Health Insurance Program, just call it a few additional things. We talked about pediatric measures. We do collaborate with the Medicaid Medical Director Learning Network, so trying to spread transformation, really trying to encourage them to test some of these new payment models like ACOs, primary care medical homes, et cetera. And then we talked about the Innovation Awards in pediatrics. How's the world changing for pediatrics? I do think it's becoming more value-based. I think your reimbursement models over time will become more and more value-based. I think private payers will follow suit. You know, I do think there's real issues about what are the right measures. How do you do risk adjustment well in kids, and what are the differences? You know, how do you account for the various populations a place like Children's National serves? And so don't want to minimize that, but I think broadly we're trying to use our various levers to move to more of an alternative payment model, value-based world. ACOs are growing rapidly, including pediatric ACOs, not growing as rapidly as adult-based ACOs, if you will, but we do see more uptake in pediatric ACOs. There are some challenges. This is a good example where your payers cross multiple state lines, so how do you deal with the issue of, you know, you've got even increasing complexity on sort of how you deal with this environment here, which I talked to here, the challenges, you know, payers are state-based. The attribution issues, you've got a large enough base, maybe less of an issue for you, but attribution issues and sort of sufficient sample size in kids can be real issues. The quality measures, as I said, I think still want a more robust set, so we're not sort of racing to the lowest common denominator, if you will. But do think there's opportunities to coordinate care, especially for children with multiple chronic conditions. Life trajectories, we won't talk about today, especially because you're pediatricians and you know it, but life trajectories are modifiable and compoundable over time. There's good evidence, so investments in kids will lead to positive long-term health trajectories, which are actually good for our nation. I know your advocacy through CHA and other places tries to help folks on the Hill and otherwise, and I can never ask you to lobby, but realize that. You know, core quality measures, we basically talked about this. Just spend a minute on this slide, given the audience. This is my last slide, so we will have time for Q&A, especially because I know we've got sort of trainees of all. We've got some senior people in the room, obviously, but we also have trainees, et cetera, going around. I do think physician and clinician executive leadership is critical. And I'm not sure our training systems are always set up to foster that as effectively as they could. And I'll briefly tell you about my story and then tie it back to that. And I'm not an expert here. You've probably got real medical education. Actually, I know you have real medical education experts in the room, so this is always dangerous. This would be like you could give me a lecture on ACOs. So I will say something and it'll probably be wrong, and you can tell me later, Mary. But yeah, just briefly on sort of my story and then education. So, you know, I worked for McKinsey Consulting out of undergrad, and then when I went back to med school, people were like, what are you doing? Why are you giving up money and everything else to go back to med school? And I was like, because I want to be a doctor. The 4 things that have driven all my decisions are family, impact, which for me is the triple aim, learning, and peers. And when I stick to those 4, it's worked out okay. Those 4, by the way, I've been married now 10 years or so. I should know that. We have a family mission statement, which basically embeds those 4 things that my wife made me write, but has actually been helpful. So once again, she was right. So went to McKinsey, went back to med school, you know, trained in pediatrics, loved kids, knew I wanted to do broad system stuff, but wasn't sure what. Did RWJ because I still was like clinical scholars program, not sure exactly what I want to do, but I want to work on system issues. You know, went to Cincinnati Children's. At that time, just, you know, great set of mentors for quality improvement and other things, and, you know, had family in the area, et cetera, and just knew I'd get great mentorship. each time when I left Boston, I don't know if it happened to you, they were like, you can't leave Boston, like you'll never make it back. And I was like, I think I'll be okay. Like when I left CHOP, they were like, oh my God, you're going to Cincinnati, like what's going to happen next? You're like, really? I'm pretty sure it'll be okay. You know, I did the White House Fellowship and I was applying for a K award. They were like, oh my, you can't, like you gotta stay, you gotta get your K, and then you're like, this is crazy. Now luckily there were other people in the institution that were very supportive, but it was mixed. And I had to learn a lot of these skills along the way. So, you know, Don Berwick hired me as Chief Medical Officer of CMS when I was 36. The path to get there was, you know, I did a White House Fellowship, and then somebody let me run a small division with people and money. I tell every young doctor, anybody ever lets you run something with people and money, if you want to lead, do it. Because the biggest mistake we make is we let people do that when they're like towards the end of their career. We're like, okay, now you've succeeded for 20 years, you can lead 10 people. You know, when I went back to Cincinnati, I was a division director. Let's be honest about that room. I was division of hospital medicine, which people were skeptical of. They were. Our chair wanted to make it a division, and other people were like, what? Those are staff positions. You know, I'm 20 years younger than everybody in that room, to be frank, in Cincinnati at the time. A year later, by the way, on hospital medicine, we were the #3 research-funded division out of all of them. We were the #2 or 3 for publications, and we had a fellowship, and it was like, really, guys? Like, this is what entrenchment gets you, which is not good things. And so, yeah, I think there's lessons on the training and opportunities we give people, and I've been lucky, and I couldn't recreate this if I wanted to, and it's not like I'm like, here's your map. But I do think, you know, Don let me then be CMO, and then when I ran the Innovation Center, I didn't know finance. I told the secretary, I was like, you realize I'm not a finance guy, and you're going to make me run the biggest, like, finance engine in the country. She was like, yeah, but I think you can do it. And I've learned a lot of finance. So I think there's lessons here on training along the way. I think there's lessons on risk-taking and being willing to take risk, and that's bi-directional, by the way. I've hired people for roles that I'm like, oh my God, I hope it works, because they're pretty out of the box. But a lot of times it works. There was just a great Wall Street Journal article about the best CEO leaders in America. They encourage their good people to leave. They're like these spreaders of networks. And so, sorry if this is like a random, I don't usually do this part of the talk, so this is my first test of it. I'm not sure if it went well or not. You can tell me afterwards. But I do think there's some lessons on how we think about leadership training, et cetera, both as the learner and the teacher, if you will, that I think we should think hard about as we move to this new world. We're going to need a whole host of people, and this isn't just doctors. This is clinicians, administrators, nurses, everything across the board that are trained in some skills that were not necessarily what some of us learned when we were in training. So how do we embed those skills in that type of culture? So with that, I'll stop, and we've got a few minutes for questions or comments. Thanks a lot for having me. I just call on people. And if you don't mind, oh, there's a mic, even better. If you don't mind saying your name, where you're from.
Hi, I'm Shadi Ogunlesi. I'm a pulmonologist here.
Great.
I'm also on the Grand Rounds Committee. So let me give you my feedback right now that the last part was the best of this. Thank you so much for that comment.
Try to do it again.
I was going to ask that. How do you translate that for many of those that, you know, were training and were coming behind us? The other part of it, which is my question, is you showed very briefly on readmission. And I'd like you to break it down simply to how do we, as faculty members, as leadership, translate that in teaching to our residents? How do we imbibe that in the pediatric world? We know it's very prevalent in the adult world now. Thank you.
Yeah, so a few brief thoughts, and I'll try to be brief on the answers. Just I know we're almost at time. One, on the policy construct, we have to realize, and we say this in Medicaid programs, that risk adjustment, some things may be different. But then directly on your question, you know, what I would think about and what we used to do in Cincinnati as well is and I'm probably going to tell you things you know, but breaking it down into the different populations that are readmitted, then their root causes for readmissions, and then how you would address those root causes, so what are the key drivers and how you would address them. It may be different here. For Cincinnati, there were basically 3 populations. You could get more complex. There was there was a population that just something happened, they need to be readmitted. We didn't really view as preventable. You're not going to do that much about that. It's probably in your baseline rate. There was a population that really complex kids that had a series of medical interventions that could have, largely medical, that could have prevented readmission, whether it was medication related or follow-up related or, you know, specialist sort of tied in related. One of our biggest buckets, what I would guess is here too, is what I'll call socially related readmissions, which I would argue, and we get in discussions with this with the hospitals sometimes, we should all still care about. We can debate how much is truly preventable or not. I try to avoid that debate because I just want to work on improving it. But it's a legitimate debate. And those, I think, we ended up working on things like transportation and housing and other things. One of our pioneer ACOs is now a next generation ACO, so at full risk, Montefiore in New York, big safety net provider. They finally just built temporary housing. Steve Safier is a great guy. He's like, I'm done. The city can't solve this for me. I'm at full risk, and I see my homeless population, now that I'm at full risk, is like through the roof in readmissions and costs, et cetera. I'm going to build temporary housing. I'm going to get them back on their feet. I'm going to get them a job, and that'll actually, he can show a return on investment in our model, which is really like mind-blowing. But I think it opens, that's what I mean when you open up the possibilities. I have a Cleveland clinic who's thinking about joining our next generation ACO. At the point they realize like they can just do telehealth and remote monitoring and you just care for it however you want. I don't care. It like opens their mind to the possibilities and really drives innovation. A few thoughts. Sorry, I'll try to be briefer in the answers. All right.
Yeah, I have a question. Good morning. Your presentation was excellent. I'm Dr. Cora Bramble, Chief Medical Officer for Ambulatory and Community Health. You were speaking to in one of your slides specifically as it relates to the attributable population, that if you don't have it at the MCO level or at the hospital level, that it poses a challenge. So for those of us that are in that quandary, what are your words of wisdom?
I'll give you words. I'm not sure if there'll be words of wisdom. And I really don't, you'll have to, sometime I'd love to be educated more about your exact payer market because you probably know things I don't. I think a few things that we've seen that could be successful. So I think for some MCOs, they'll realize that, they're being paid capitated rates, and then at a very high level, and I don't mean to minimize this, they have 2 choices in life, and there's a spectrum in between. One is try to charge really bad fee-for-service rates and hope they charge bad enough rates that the numbers work out for them, not to be too frank about it. On the other end is like true care management. Like I'm actually going to manage care, I'm going to get better quality, lower cost, that's how I'll be successful and everything in between. I think if you have MCOs that are closer to this end of the spectrum, they may realize that for them to be successful in complex kids or healthy kids, like you are the dominant provider in this area, they have to partner with you. And we're seeing both in Medicaid and Medicare, people that basically take their capitated rates and they'll turn it around to be totally capitated or partially capitated to network providers that they know, trust, and it becomes a deep partnership. Like when it works well, it's like, it's not adversarial. You're like in this together. And if you're successful, they're successful and vice versa. Getting there, the challenge is like, it's all local. Like, what is your exact payer mix? What's their ability? And, I will tell you, we put in a Medicaid managed care rule that was the biggest change in Medicaid managed care in at least a couple decades. And it really pushed broadly, and now we got to see if this translates down. You got to pay reasonable fee-for-service rates. You can't just cut rates and have bad access. You got to really do care management. You got to report to us how you're doing care management. So we are trying at a national level as well to have Medicaid managed care be much more innovative and accountable, if you will. And Mary, you tell me when I have to stop.
I'm going to really step outside the box here. I'm a nurse case manager for the Panda Palliative Care Service here at Children's. I work for Mary Damont, sitting down there in the front row. I would like to see a core measure for concurrent care, end-of-life care. That is my biggest fight, and challenge is trying to get concurrent care for some of our kids.
Yeah.
And try to figure out how to do that, working with an insurance company that says I have to follow Medicare guidelines for a kid.
Yeah. This is a
Sorry.
great one. And actually, you can test this with them now. So some people have to go, that's fine, I'll answer this question. And it's going to be a good answer, though. I pre-warn you because I love this question. So you may not want to leave. This is a huge issue, and I'll try to be brief. You know, in Medicare, certainly I've dealt with this as a physician, and Medicare dealt with it with my own father. By law, our current system makes no sense. So if you get curative care or you get palliative care, for Medicare to make sure you know, and you can try to use this with your payers and see if they buy off on it, we are currently testing in 40 states concurrent hospice and palliative care with so-called curative care, which is much more natural progression. It's up to the patient and the physician and clinician and care team how people enter that model. The private market, Aetna and others showed this. You can improve the best study in New England Journal. You probably know this, but some may not. Better quality of life by far for patient and family, better quality of care, lower cost, actually longer longevity, probably because didn't get a lot of interventions that weren't all that helpful. In this hospital, I don't usually tell the story, she's told me I could and I still won't say who it is. You know, I took care of a child and a mother that I also saw multiple weekends and had a series of discussions with that led to that child entering palliative care. That child has passed away. One day I'm literally in CMS, you can't make, and like, this person shows up. And I'm like, how's it going? She's like, do you remember me? I'm like, of course I remember you. She had been in federal government and transferred into CMS, into the unit I was working in, so we could work together on some of these issues. So, you know, I think, as you know better than most and probably better than me, this also gets to training. I learned by doing and probably not doing well at some point in my career. You know, I think these palliative and hospice and end-of-life issues are real, critically important, and I think the good news I'll leave you with is I think we have shifted the dynamic of the rhetoric where we're, I think, trending in the right direction. Thanks for your time.
Thank you very much, Patrick.